Now let's start. This webinar is about the optimizing OCT usage in glaucoma management. So instead of going details in the literature data, I will try to concentrate on the practical aspects and practical usage of OCT in glaucoma management with interesting case examples. OCT in glaucoma and diagnosis and follow-up. OCT revolutionized glaucoma care. Currently, it is the most important tool for early diagnosis and treatment of glaucoma, and it replaced all previous devices for diagnosing structural damage and became gold standard. As a glaucoma specialist, I am fascinated with this incredible technology for the last 15 years as it revolutionized the glaucoma care completely. Current status of OCT in glaucoma is very important to us. OCT can evaluate RNFL, optic nerve head, macular ganglion cell damage at the same time. With OCT, we can diagnose glaucoma at very early stages, many years before visual field defects emerge, and even OCT RNFL defects appear. Unfortunately, as with any new technology, it takes time for users to understand the full potential, and currently, I think it's not reached in many clinical settings. In high-volume clinics, most clinicians just look at the red and green colors in the pie graphs, which can be misleading. A good knowledge of OCT basics are required for understanding the potential limitations and pitfalls. Any experienced clinician can interpret an OCT report in few minutes using a systematic approach. So, glaucoma is a disease that affects ganglion cells. Ganglion cells form the inner retinal layers, and their axons form the RNFL, which converge to optic nerve head as a neuroretinal rim. With OCT, we have a chance to identify the damage to the ganglion cells at the macula, at the RNFL, at the optic nerve head with very high reproducibility. RNFL scans are the most studied OCT parameter. It's easiest layer for OCT devices to evaluate, and all OCT devices can evaluate the RNFL thickness. So, how to interpret an OCT report in a short time? We have to remember the basic points. Cirrus HD OCT uses 3 different false color codes. It's different in different parts of the report, so red is good in some parts while it is bad in others. For RNFL thickness maps, which shows the raw RNFL thickness data without any statistical comparisons, uses the thickness color code. And that means thicker RNFL is warm colors and thinner RNFL is on cold colors. For tomograms, we have the reflectance code in which red means highly reflective and tissue, and where black means no reflectance from that tissue. For the rest, where we have statistical comparisons, we have the statistical codes where the green and white is normal and whereas yellow and red is abnormal. Correct understanding of these codes are essential for correct interpretation of these results. So, when your technician hands you a Cirrus report, you have to be sure that the quality of the scan is good. Otherwise, you have to repeat it. For evaluating the quality of the scan, at first, we must check the patient data like name, date of birth, and as normative database comparisons are age-matched, this is very important. After that, we have to check the signal strength, which should be at least 6 or more, recommended by the manufacturer. Poor quality scans results in thinner RNFL measurements. The second part we look is RNFL thickness and deviation maps in which you can see important quality issues even the signal strength is good. The disc must be in the center of the scan. RNFL thickness and deviation map should look artifact-free. Cirrus shades areas that can be scanned as black. If the unscanned area coincides with the calculation circle, the T-SNIT data and all the thickness pie graphs will be affected. In addition, eye movement artifacts or optic nerve head identification errors can be observed on these maps. Second, check the RNFL and deviation maps for the extracted horizontal and vertical tomograms. Horizontal and vertical tomograms are helpful for observing the depth and topography of the cup, for identifying artifacts caused by the disc anomalies. You see tissue remnants preventing correct optic nerve head topography, or vitreous tractions that can cause green disease artifacts. RNFL circular tomogram is the OCT image of the calculation circle which the segmentation is performed and RNFL thickness values are calculated. All T-SNIT data is calculated from this tomogram. Check it for artifacts like vitreoretinal interface problems or unscanned areas like these ones. So how to interpret series OCT results systematically? This is my own algorithm in my mind. I start with the RNFL data. For RNFL, the first strategy for series is to construct the 3D volume data of the RNFL around the optic nerve head. This volume scan is not available in all OCT devices. And if you are dealing with glaucoma, I think these volume scans are very important. In series, the optic nerve head disc cube is 6 × 6 mm scan area. It consists of 40,000 A scans. It's the raw data, which means actual measured values, the raw data of the scan, and they are not related to normative database values. So they are less vulnerable to the anatomic variations or the artifacts. An experienced clinician can tell a lot about the health and distribution of the RNFL from these thickness maps. And comparing two eyes with each other is very important. We have the thickness color code in these maps. So warm colors, thick, cool colors, thinner areas. Secondly, we check the RNFL deviation map. This is the UNFAS infrared OCT image of the disc area, which is overlaid with statistical comparisons to the normative database values. So now we are comparing the raw data with normative database. Regions with normal thickness do not have any green overlays. Regions thinner than all but 5% of normal are overlaid with yellow superpixels. And regions thinner than all but 1% of normal are overlaid with red superpixels. Infratemporal RNFL defects are the most common defects in early glaucoma, and we call this area as the macular vulnerability zone. The second strategy for series is to measure and evaluate RNFL thickness data from 3.46 mm calculation circle, which is automatically centered to the BMO. Thickness measurements are plotted in a color-coded, statistically color-coded background. You can see all RNFL defects and most artifacts and anatomical variations from this T-SNIT plot. Then we have the RNFL quadrant and clock hour graphs. These are the summaries of the RNFL data from T-SNIT plot. As they do not give additional data and vulnerable to the misinterpretations, we must be very careful to check the T-SNIT plot before reaching conclusions from these pie graphs. They can hide small dents in the T-SNIT plot, which is one of the reasons for the green disease. And the results are compared to the age and disc size meshed normative database values. After we check the RNFL, we look to the optic nerve topographic data. We have the neuroretinal rim thickness graph, which is also in the T-SNIT configuration. The thickness values show the distance between the BMO, which represents the border of the optic nerve head, and minimum rim width border, which represents the border of the optic cup. We also check the extracted tomograms to see the optic nerve anomalies, cup depth, and centration. Finally, I check the key parameters table, which gives the key RNFL and disc parameters for both eyes. The results are compared to the normative database values as they are statistically color-coded. We check the inter-eye symmetry, and also we evaluate the concordance of RNFL and CUP results. This is a very important point. It is very important for diagnosing the glaucoma masqueraders. We will have few examples in next part of the presentation. Then we have the macular scans for glaucoma. Nearly 1/2 of the retinal ganglion cells are located at the macula, so it's very important to check the inner retinal OCT scans. Macular OCT in glaucoma shows us the retinal ganglion cells loss is common and can be detected in the macula at early stages of glaucoma. It can occur early in disease, but can be missed or underestimated with standard visual field tests using the 6 degrees grids, such as 24-2 visual field tests. 10-2 or the new 24-2C is good alternative not to miss these defects. The importance of the macular region in the glaucoma is underestimated till today, because we didn't have any test that can show us the ganglion cell damage in macula structurally until the spectral domain OCT with high resolution was available. Again, we have the macular analysis false color codes. It's like the same with the RNFL. We have the thickness code, we have the reflectance code, and we have the statistical code. And finally, I look to the panomap analysis, which combines peripapillary scan with macular scan to provide panomap report, which show us the wide field view and summary of the results. In this patient, you see a perfect example of damage at the macular vulnerability zone, and panomap analysis is a good feature of Series 5000. It will be more easier with the faster Series 6000. So in summary, if I have one OCT in my hand, I will finish it less than 1 minute. This is the steps. I check the quality, I check the RNFL damage, I check artifacts and anatomical variations, I check the optic nerve head topography, I compare RNFL, ganglion cell, and optic nerve head results, and I ask myself, are these findings coherent with the patient's clinic? This is very important. So you can reach a final decision in less than 1 minute. I like this slide. It's from my friend Sanjay Asrani from Duke. He likes that. Unfortunately, these machines has no brains. One day they will include more artificial intelligence, but till that day, we have to use our own brains for these machines. We have to check for artifacts and anatomical variations all the time. So we can differentiate field disease, artifact or anatomical variation. These can occur nearly in 1/3 of the cases. One important concept here, that's the floor effect. The current segmentation algorithms never measure RNFL thickness less than 40 microns. So even in blind eyes with end-stage glaucoma, like the left eye of this patient, OCT will measure some degree of RNFL, never less than 30 or 40 microns, depending on the machine. If RNFL thickness values is less than 40 microns, re-evaluate this scan for artifacts or image quality issues. The floor effect and imaging artifacts can be easily observed when we check the T-SNIT curve, which gives us all the thickness data from the calculation circle, and it has the classic double hand configuration in normal eyes. An experienced OCT interpreter can reach all the conclusions just looking to this curve, as it has all the data from the scan for the calculation circle. What are the common causes for artifacts or anatomical variations? We can think about the imaging problems, scan quality, segmentation errors, and we have the patient-related ones, anatomical variations, mediopathies, vitreoretinal interference problems, optic nerve head drusen, myelinated nerve fibers, etc., and uveitis. I will show some examples of them. There is two things we call them as red disease and green disease. Red disease is the false positive result. OCT looks like glaucoma in a healthy eye. It's surprisingly common, and I will show you some examples of it. This is an OCT with a lot of RNFL defects, low average RNFL thickness values. If you can read it, it's 73 and 70 in the right eye and in the left eye. In the rescan of the same patient, now we have much better OCT with thicker average RNFL values, which are now in normal range for the right eye and borderline range in the left eye. What's the reason for the change in OCT results in this patient? Look at the signal strength. It was 3 and 4 in the first one, it was 7 in the second scan. So signal strength, better signal quality results in better and more correct RNFL values. So you have to rescan patients until you have good quality scans. This OCT has a good signal strength, at least acceptable, 6 to 7. But the right eye show a lot of reds and yellows. Why? Rescan again, and the OCT is completely normal. When you look to the RNFL thickness map and deviation maps, you see here the motion artifacts and poor centration of the disc. You see the vessels are not continuous, so I moved during the scan. So having good signal strength does not always guarantee good scan quality. You have to look for the other clues. So eye movements and poor centration is one of the reasons for the red disease. In a recent study published in Ophthalmology Journal, this is an interesting study. I just read it while I'm preparing this webinar. Authors showed the importance of signal strength and artifacts in a very large series. Interesting point in this study is although ZEISS recommends using scans with SS higher than 6, in mild to moderate glaucoma, signal strength higher than 3 can still be used unless it's artifact-free. The results are changing just a little bit. On the other hand, if signal strength is high, artifacts can affect prepapillary RNFL measurements significantly. If it is impossible to get rid of local artifacts in scans, one can still use the data from the artifact-free areas of the scans. So how to improve the scan quality? To increase it, we need clean optics and OCT device in a good condition. Older devices must be serviced and cleaned by the manufacturers. Device position in the room, light effects, pupil size, and also air conditioning vents may dry the eyes of the patient. So do not place the devices directly under air conditioning vents. If patient has dry eyes, use artificial tears. Technician experience is very important. Pupil dilation may help in difficult eyes. And if a patient has significant cataracts, cataract surgery may help also. And now, anatomical variations can occur in nearly 1/3 of the cases. Few examples. All devices use normative databases for comparison and classify patients according to these comparisons. These databases have around 200 to 400 normal eyes, depending on the machine. And number of high myopes and hypermetropes are few, and optic nerve head and RNFL have great variations like tilted discs, small or large discs, and also race is an important factor. This is my example. Look at the height of the players of great Fenerbahce basketball team, that's my team in Turkey. If you have a normative database of certain number of basketball players and compare their height with them, this will be the possible result. Most of them will be in the green zone, but few outliners will be in the yellow borderline zone or in the red zone. And these people will be flagged as abnormal. That's what happens in OCT. The same thing when the OCT compares the patient's results with the normative databases. If the values do not fit the normal range, then they will be flagged red as abnormal. This does not mean there is damage every time. I want to show some common examples. What do you think? Are these superior NFL defects are real damage? Macular scans look normal. The Tisnet plot shows a typical exaggerated two-hump pattern with a depression in between, and the machine thinks this is an RNFL loss in this point. You can see two humps and a depression in the middle. We have the red-free photos of the patient also. The RNFL thickness map and the red-free photos shows that the superior RNFL enters optic nerve as two bundles instead of one. You can see the RNFL bundle, one is here and second one is here. The same on the other eye, and here you see it also. It's like two bundles coming inside the optic nerve head. So the area in between is flagged as red by the machine. This is a common anatomical variation called split RNFL, and it's one of the most common anatomical variations we see in our patients. Never miss it. This is also an interesting and very common one. I have seen totally normal teenagers started on glaucoma medications because of these variations, as it's more common in myopes and we have having more and more myopia. There are symmetric inferior RNFL defects here. You can see them here and here. When you look to the macular area, there is no defects. And when you look to the Tisnet plots, you see RNFL thickness is quite good, but the RNFL pattern does not fit to the expected normative database areas. Looks, it's in the red here. If we can move the Tisnet maps to the left or nasally, we will see that RNFL thickness will fit to the green area for both eyes. RNFL bundles follow the major retinal vessels, so if the retinal vessels are not at the expected place, we see this artifact. It's common in myopic eyes, and we call it temporal RNFL shift. We may see nasally shifted RNFL in some hypermetropic eyes, although it's less common. This patient has both split and shifted RNFL, which is more prominent on the left eye. You see it's the split, and here it's shift. You see the inferior of the left eye is shifted, and it's split for the superior RNFL. Look at this black area. It's an easy one. It means retina was not scanned there. It is evident on circular tomogram and also on Tisnet plot. When you ask the patient to move his eye and rescan him, after a few eye movements, the white ring is out of the way for the calculation circle. Also, the clue here is the zero RNFL thickness in this Tisnet plot. As we said, because of the floor effect, it's never possible. This is the white ring causing red disease. We will see examples that white ring doing funny things again. Green disease is just the opposite. It's the false negative result. OCT is normal in a glaucomatous eye, but it's much less common. Generally, vitreoretinal interface problems is the main reason for the red and green disease. White ring can also cause this kind of strange-looking artifacts and result in green disease. You see like this eye having nearly two discs, double disc eye, and it's causing problems with the statistical comparisons. So white ring may cause green disease. Another patient, this is a glaucoma patient, but RNFL thickness looks very good. But when you look closely to tomograms and look to the discs, you see that especially on the left eye, there is cupping. When you look to the visual fields, there is damage. When you look to the macula, there is damage. This is the green disease artifact. You see here, I don't know if you can see it completely, but there are vitreoretinal interactions causing RNFL to look thicker than normal. The same thing happens when there is uveitis. When the uveitis is active, you see the RNFL, you have the RNFL edema, and you see the RNFL very thick. And in this eye, like the vitreoretinal tractions or in uveitis patients, when these tractions go away or the uveitis subsides, you will have a very fast progression and you start to think what's going on. Actually, what's going on is there is the RNFL damage, but you start to see it. These are the areas of distractions. Also, there are some common ocular pathologies that make OCT evaluation very difficult. Just few examples. You see there are a lot of vitreoretinal tractions here and a lot of unscanned areas here. These are the vitreoretinal tractions. This is an asteroid hyalosis patient. It's very difficult to evaluate them with OCT. This OCT shows a lot of red areas. Also, macular OCT has defects. We have visual field defects. These are very, very difficult patients as these changes can be progressive also when they have glaucoma. You see, these are optic nerve head drusen and they can cause visual field defects looking worse in time. Other peripapillary abnormalities like myelinated nerve fibers of the RNFL cause segmentation and follow-up problems also. You see there is a very thick RNFL in this eye and it's very difficult to see if this cupping is glaucomatous or not. Also, are all RNFL loss on OCT means glaucoma? A good question. When you see RNFL loss, do not forget to check the vertical and horizontal tomograms and RNFL deviation maps, disc data, and also neuroretinal thickness T-SNP plot, in addition to the CD cup disc ratios on the summary parameters table. You see a lot of RNFL loss, but RNFL is nearly gone, but there is only few, just small amount of cupping, and you don't see any cupping in extended vertical tomogram or extracted horizontal tomograms. When you look to the patient's disc, you see it's optic atrophy, not glaucomatous. Another patient with RNFL and macular damage, you see the macular ganglion cell map is red. You see OCT angiography, there is capillary dropouts. There is visual field defects on the right eye. Although there is some degree of asymmetric cupping, this patient has a small crowded disc. With this degree of significant damage, we expect to see near total cupping. So our diagnosis in this patient was non-arteritic anterior ischemic optic neuropathy. You see the right optic nerve is nearly chalky white. These are for single OCTs. A single OCT is very important for the diagnosis of glaucoma, but we have more important weapon for diagnosis and follow-up of glaucoma. With the use of OCT progression analysis, we have the chance to diagnose glaucoma at very, very, very early stages. A single OCT report is the patient's current status. It depends on normative database. It's the patient versus normative database game. Anatomical variations affect the results, can be normal even with significant RNFL loss in eyes with thick baseline RNFL, which is progression in green concept. We will talk about it. On the other hand, OCT progression is progression in time. It's patient's history. It does not depend on normative database. It's patient versus patient's own baseline game. Anatomical variations do not affect the results. It can show damage even before OCT becomes red. It is an objective method for structural progression. It does not depend on patient subjective responses. This is what I like the most. It does not depend on normative database. So it's not age, race, or refractive error dependent. Spectral domain OCT has high reproducibility with low retest variability. So it's very stable. Structural progression often precedes functional progression, and it can detect progression at pre-parametric stage. I like this slide a lot. This is Dr. Weinreb's classic glaucoma continuum diagram. It's not a nice analogy. We don't like to compare anything with cancer, but glaucoma for me is the stage of metastatic disease, this stage, when it's too late for modern glaucoma practices. Then we have the pre-parametric glaucoma, which I think it's the local disease stage. You can see visual fields are normal, but there are structural damage. You can easily catch the patient here. But when you are familiar with progression in green concept, for me it's the carcinoma in situ stage. You can catch the disease in very, very early stages, and which is not possible with any technology in the past. Like visual field progression, we have event and trend analysis in OCT progression software. Event analysis compares the baseline and follow-up measurements for the specific points. And if the difference is greater than the test-retest variability of the device, it confirms progression. This is the point A compared with serial scans. On the other hand, trend analysis is the thing we try to estimate the future by using the regression analysis concept. This is what happened and what will happen in the future. This is the Cirrus GPA report. I want to have some time on this report. I think this is the most important report of the Cirrus OCT, and it is the most statistically good report in any OCT device for me. It has very different concepts for looking for progression. First one, there are 4 different strategies. First one is the RNFL thickness map progression. You see serial RNFL thickness maps and change maps. If the change is greater than the test-retest variability, superpixels are flagged with yellow and red. Second one is RNFL thickness change graphs, which is the trend analysis part of the GPA. RNFL thickness values of the calculation circle are plotted as a function of time for the average, inferior, and superior quadrants. The slope of regression line is also presented as the rate of change per year. Third one is the RNFL thickness profile change map, which is again an event analysis. 3 profiles for the examined eye is plotted and compared with overlapping style. B1 and B2 are the 2 baseline scans, and C is the current scan. I like and use it a lot. I show the patients this all the time. And we have the RNFL optic nerve head progression summary. At the second page, we have the RNFL and optic nerve head summary parameters table. This table summarizes the data that were used to draw the plots in page 1 and uses event analysis to compare with the values with the baseline. So if we can read the report like this, we can go on with the ganglion cell GPA. It's nearly the same concept, the same maps. So I will not talk a lot about this one. OCT progression has some limitations. We do not have randomized multicentric studies based on OCT results. Most of our data from studies like early manifest glaucoma trial or ocular hypertension treatment study were from pre-OCT era. Disease severity is important. RNFL progression data is not effective in advanced glaucoma. You know the floor effect. Age-related changes in RNFL and macular thickness is important. No, it's not included in current commercial software of any device. It must be taken in the consideration for progression. OCT quality may worsen over time. Cataract and vitreous opacities affect it. And high myopia makes progression analysis difficult. Few cases now. This is an 8-year-old monoocular lady with pseudoexfoliation glaucoma. This is a very demonstrative case for fast progression. She had systemic health problems and missed the follow-up for a year. She presented with an IOP of 29 despite maximal therapy. And during this 1 year period, both OCTs and visual fields showed a very rapid progression. You see the rate of average and superior and inferior RNFL thickness loss is very fast. The slope is very fast. And it's also, you can see it on the visual fields. This is another interesting patient, and I want to stress on this patient a lot. She was a 65-year-old lady diagnosed as glaucoma suspect in 2010. Her IOP was 32 in both eyes. Medical treatment was started and followed till 2013. Her IOP remained around 23 in the right eye and 18 in the left eye. In her 2013 OCT, there are just few clues about glaucomatous damage, but it's nearly normal, green range, only a dent here. You can see it here, and it's yellow. And Humphrey visual field of this eye, of the right eye, was completely normal. When we check her GPA reports, it's a completely different story. There is a very fast progression in the right eye, losing around 5 microns per year on the average RNFL. You see from 91, 93 to 77, and around 8 microns per year at the inferior and superior quadrants. You can see it here. So, despite maximal medical treatment, she is progressing. A trabeculectomy was performed here at 2013. Her OCT reports just after the trap in 2016. If we check the progression report with original baselines, we still see a lot of progression. Look this. But if we change the baseline to the date of trap, now we see the patient is stable. So don't forget, the baselines must be checked to see if they are relevant for the current exam of the patient. If a major change in treatment plan was done, the baseline must be chosen accordingly to see the effect of the current treatment plan. And this is the progression in green concept. This is the second and maybe more important point in this case. I choose to operate on a patient with normal visual fields and near normal OCTs and marginally controlled IOP. Is there any scientific evidence here? On serous OCT, and this is nearly similar in all other OCT devices, if average RNFL decreases 5 microns, it is statistically significant, and it is true progression in 97.5% of the time. So changes of this magnitude that are confirmed on a second test have been reported to randomly occur on less than 1% of the time. So it's real progression. These are the normal, borderline, and outside normal values for a 69-year-old average person. You see it's 107 at 95 percentile. Let's think she is a glaucoma suspect. She can start from the top, and RNFL thickness decreases in time, but she is still in the green range. This OCT thinks in the normative database comparison, she is still normal if she lost this amount of RNFL. We call this progression in green. Average RNFL thickness does not become yellow until the 5 percentile, where we start to classify the patient as preparametric glaucoma in this area. Spectral domain OCT can measure 4 to 6 statistically significant progression steps for a glaucoma suspect while the patient is still in normal green range. So if we miss this RNFL loss, a glaucoma suspect can lose nearly 1/3 of her RNFL thickness and nearly 300,000, maybe 400,000 estimated ganglion cells, and still you can have a normal OCT scan, as normative database says so. This is where the progression in green, we see the patient. We can look for the earliest signs of glaucoma here, And this is the normal limit for the OCT, for the RNFL, for the optic nerve head, and for the visual field, it takes too much time. It's really a lot of loss for the patient. Sometimes macular GPA is important. This patient with no progression on visual field GPA, but during 7-year follow-up, RNFL values showed progression, which is also confirmed with ganglion cell GPA, and sometimes progression can be seen on macular OCT better. Poor quality scans, motion artifacts, cataracts, vitreous opacities can easily trick GPA, so be careful. In this case, you see the Weiss ring sitting here, causing a drop in the measured RNFL, and the GPA says there is progression in all boxes. So be careful for artifacts in GPA also. And fifth, summary slides now. OCT shows us structural changes starting as early as preparametric glaucoma stage. With OCT progression analysis, we can monitor the disease, and in addition, we can diagnose damage even before using the progression in green concept. Visual fields shows us functional changes, but the damage starts much later on the visual fields. We have new exciting developments that can help us in the future for better understanding the structure and function relation. These include new visual field algorithms like 24-2C, new OCT reports like the Hood report, which will be available on Series 6000, and software integration of visual field and OCT data like the Forum software, which is very important. With the introduction of this software, we have a chance to combine structure function in a single report in many different ways. So we can save a lot of time for busy clinics. And in addition, we can really optimize the visual field and OCT evaluation for improving patient care. Also, the exciting new development is OCT angiography. You see normal and glaucoma and advanced glaucoma patients. I think in the future, it will become more important for clinical practice. Thank you all for your attendance. Hope to see you in my wonderful country after we wake up from this bad nightmare. And I'm happy to answer your questions now.